3, 2, 1.
Hello, everyone. Today, we're going to walk through a classic diagnostic algorithm for evaluating a patient in a coma. This flowchart provides a structured, step-by-step approach based on key elements from the history and physical exam. Remember, this is a framework to organize your clinical thinking in an emergency. We start at the bedside of an unresponsive patient. Our first critical question is about the history. Is there a history of drug or alcohol ingestion? This immediately splits our pathway. If the answer is yes, we consider conditions directly related to intoxication or withdrawal, such as alcoholism, delirium tremens, or opium poisoning. If the answer is no, we must proceed with a thorough physical exam to find the cause. Our next step is the neurological examination. We look for focal neurologic findings, weakness on one side, unequal pupils, abnormal reflexes. If focal findings are present, this points to a structural brain problem. We must quickly determine if there is papilledema, swelling of the optic disc seen in the back of the eye. With papilledema, this indicates increased intracranial pressure. Think of a space-occupying lesion like a brain tumor, brain abscess, or a large intracranial hematoma. Without papilledema, the most common cause here is a stroke or a hematoma, like an epidural or subdural hematoma, that hasn't yet caused severe pressure changes. If focal findings are absent, we move to a different set of clues. With no focal signs, we turn to other exam findings. First, smell the patient's breath. A sweet, fruity odor suggests diabetic ketoacidosis. It can also be present in some cases of alcoholism. No sweet odor leads us to check for fever. Check for fever. If fever is present, this signals an infectious or inflammatory process. We must check for nuchal rigidity, a stiff neck. Stiff neck present. This is a classic sign of subarachnoid hemorrhage or meningitis. Stiff neck absent. Consider acute encephalitis, heat stroke, or severe systemic infections. If no fever is present, we proceed to our final step in this algorithm. Our last major clue comes from listening to the chest. If we hear sibilant wheezing or crepitant crackling rales, this points to primary respiratory or cardiac failure as the cause of cerebral hypoxia. Think of congestive heart failure or severe emphysema. If there are no significant rales, the list of possibilities is broad and includes metabolic, toxic, and psychological causes. Insulin shock, severe hypoglycemia, severe anemia, hepatic coma or uremic coma from liver or kidney failure, concussion, postictal state after a seizure, hysteria, a conversion disorder, carbon monoxide poisoning. Summary. 1. Start with history, drugs, alcohol.